Me all for this month clinical meeting is going to be from the Department of OBG as well as Pediatrics. The first talk is going to be from Dr. Suganya. The sperm, what men should know. I'm sure what everybody should know. Over to you.
Good morning, all. Greetings from IVF department. It's nice to see a lot of crowd. I think the hall is full now. Why we chose this topic is sperm, what men should know. It's like quite an interesting topic. You know what? The reproductive potential of any men or women can be predicted little earlier. For a girl, if she attains a puberty, if she's bleeding regularly, if she's having a regular menstrual cycle, then it is almost 40 to 50% it is understood she is having an anatomically normal reproductive function. At least the parents or the girl will have a confidence that her reproductive potential is little better. But that is not the case for men. Even though they are masculine, they are androgenic, and then if they have a proper erection, ejaculation, still now, the semen parameters can be absolutely zero or azoospermia with normal erection and normal sexual activity. So that is why when men come to us for fertility clinics and they find the semen parameters to be very low, they are really shocked. Madam, I'm going to gym, I'm so masculine, and I'm not having any problem in my I have no sexual dysfunction. Still, why my semen parameters is like this? So that is what we thought we will have to definitely think about the sperm part, because there is no awareness on the semen analysis in any of our even our social media concepts. So how does it exactly the sperm looks like? So this is the sperm. This is a tiny weeny thing. It has a, oh sorry, it has a head, it has a nucleus, it has a centriole, a neck, and then a centerpiece with lot of mitochondria, which is giving energy to the to the sperm, and it has a tail, which beats. It has the motility. It is a lovely sperm cell because which has life. It moves. When you see the sperm under the microscope, you know how lovely it looks. The men are very sensitive, as all girls we know, but even the sperm is very sensitive. It is very, very interesting to see. Even if you put the sperm in a little bit of milder, warmer hot plate, it just stops. It wags its tail. But if you put in a proper media, it swims really fast. So such a sperm is this tiny cell. We have to really respect the sperm. So how to select this sperm best out of the better? All men may have, almost 80% of the men will have sperms, but we have to select a proper sperm to have a proper reproduction. So that is the main job that we do in our IVF lab. So how I'm going to go about this process of today's meeting is the first, once the semen is collected, what we're going to do with the semen parameters. We'll be doing a proper detailed semen analysis. And if the semen analysis is normal, and then still the patient is not conceiving, even though the female counterpart is normal, then what we are going to do the next level, that is to assess the sperm penetration or the sperm functionality. And then once the sperm function has been assessed, and if it is again normal, and still the patient is not conceiving, then what we have to do with the sperm? So that is the third thing. We have a lot of other techniques inside the lab to choose the better sperm out of the entire lot. So why it is more important to go this gamete selection? We see a sperm, it is moving, but still why we are very, very particular on having a proper selection of the sperm? Because fundamentally a normally morphological appear sperm may not be genetically normal. That is why when we even have a normal semen count, this sperm will not give us a live baby, live clinical pregnancy. Whatever the sperm looking normal, beating well, moving faster, having a normal head, still it may be genetically abnormal. If that is genetically abnormal, what happens is it will not produce a healthy baby. What will happen? It will have a compromised embryo formation. It will have aneuploidy embryos, that is chromosomally abnormal embryos. That will cause recurrent pregnancy failures. So once it will conceive and they'll go for abortion. All the abortions are blamed only on the female counterpart, not on the male. Because if the embryo is not okay, then it will go for an abortion. They will say, because you traveled a lot, you ate papaya, you ate you traveled like this, you went in bus, you worked on a laptop, so it went for an abortion, early abortions, that is less than 10 or 11 weeks. 100% it is not because of anything else. It could be only the gamete part. and 80% of the abnormality comes from the sperm. So it is the right time for us to tell the couple that it's because of the sperm abnormality, even though your normal semen count can lead to an abnormal embryo, which is causing early pregnancy loss. That is why we are very, very particular on the sperm selection. So what we will exactly do? So first, when the male comes, believe it or not, all men needs to be counseled for sample collection. Even if it is going to be an younger boy, up till 50 years, we are allowed to do an IVF. So even if he is going to be a 40-year-old male, they needs to be counseled. We have to call them to a private room. We have to counsel them how to collect their semen sample. So in IVF department, dominated only by women, we take lot of empathy, and we also have a really senior staff who will take them to a room and then talk to them privately, counsel them how to collect the semen sample. We always give them a private room and also a comfort so that they can collect it and then hand it over in a small non-toxic container, what we see here, like this, with a labeled one, because there is a lot of confusion whether my semen sample, that's the biggest apprehension for all men inside the lab. So we make it that in a non-toxic container has a proper labeling. They will write it on their own hand, they'll leave it on the, which can't be erased, which will be mentioned to the husband that they can't be erased, because they usually ask us, அழிஞ்சிருச்சு அப்படின்னா திருப்பி எங்களுக்கு மாறிடுமா அப்படின்னுலாம் கேட்பாங்க. So what we do is, it is a non-toxic container with a proper marker which is labeled, which will not be missed. And then they will collect it and then keep it inside the lab and they will go. We don't allow them to carry it outside and then bring it in their hand. We don't do that. So this is first thing, this is very, very important. If that is not made comfortable, they will not be able to collect a proper semen sample, because we have a pre-ejaculatory volume and a post-ejaculatory volume too. If there is not going to be a proper semen collection, then the count or the morphology is not going to be correct. So this is very crucial step. We don't allow them to collect it from the home or from the lab. It has to be done inside the IVF lab itself. So once we receive the semen sample, what we are going to do is, first thing, we have to do a proper semen analysis. So two things is important for an analysis. One is macroscopic examination, the other one is microscopic examination. What is macroscopic? The semen sample usually contains two components. One is from the testis, which is a very concentrated spermatozoa. And what nature has done is, this has been mixed in the fluid from the accessory glands like seminal vesicle and prostate. So once the semen sample is collected, the nature again has done, this prostatic enzymes will immediately liquefy the coagulum so that the sperms can swim, because it has a motility. So till then, the motility will be compromised in a coagulum. So once it starts liquefying with the enzymes, then the sperm will gain its motility and it will start moving. So we have to see the semen sample, leave it for half an hour, to see at least half an hour, to see whether this coagulum is dissolving into a liquefaction, because that is very, very important. Once a semen sample is dropped inside the vagina, within 15-20 minutes it will liquefy so that the sperm can ascend inside the uterus. So that is very important in doing macroscopic examination. The next comes the pH. So pH will just check whether it is an alkaline or acidic. So once we do a macroscopic, then comes a microscopic examination. So what we do in a microscopic examination? So this is how it looks under a microscope. Commonly in outside lab, what they do is, they take a small microliter of the semen sample, or maybe one drop of semen sample, they put it in the slide and they put it in a normal microscope. And this is how it looks. So they will have a counter, so they'll count the sperms, count the movement of the sperm, and then they will see the shape of the sperm. This is routinely done in outside labs, which will give only an approximate number of sperms. It's not going to give us the in-depth detail of the semen parameters. So what we should do is, we should go for counting chambers. This one is old one, which is the Newbark chamber. Once we drop the semen sample inside that, it has grits, and this is how the sperm will look like. It just moves. It moves from here to here in a very, very forward motion. And apart from this new Gover, there is a newer one again, which is the Makeler chamber. This is the Makeler chamber. This is what we use in our IVF lab. So we put the semen sample exactly inside, which has grids, and then this is all is counted. There is a way of counting. There is a way of counting for this. Not routine lab technician can do this counting. Only our embryologist can do this. They count like how many squares at the horizontal or vertical. There is a process for that. And they count and then take the semen count. Why this taking count of the sperm is very, very important is, according to WHO, what they have given is minimal 16 million per ml of sample of count should be there for the sperms which has been deposited in the vagina to travel to the uterus, to the tube, to reach the egg. So this is what the WHO standard has said, that is minimum 16 million should be there. But normal count can go up to 80 million or 100 million. But if they're going to have a 16 million, at least should be there to reach the oocyte. So taking the count of the sperm is very, very important. Randomly, we should not tell them and tell them that you are only having 5 million or 6 million, because 16 million, if they have lot of chances to have a natural conception. So the counting of the sperm in the macular chamber is very, very important. Next, after we count the motility of the sperm, it's very fast. So how do we calculate the motility? Again, there is a technique of calculating the motility of the sperm. So the sperm, again in the macular chamber, how that sperm is swirling around, how fast it is going to take from one grid to the another grid, this is how they calculate the motility. And they have classified that motility into 4 patterns: rapidly progressive, slow progressive, non-progressive, and immotile. If there is no tail movements, then they are the immotile sperms. And if they are moving, you see the distance that it is traveling. If it's 25 micrometer per second, if that is at least 25 micrometer per second, it is able to transfer. If it is able to move, then it is rapidly progressive. So that in depth, they'll see the motility of the sperm. See, commonly when they come to us with a semen analysis report from outside, they said my motility of the sperm is not okay. That really depresses the men. Unlike women, if you say women that your ovulation is not okay, she doesn't bother. But if you say men, your motility is not okay, they relate that motility to their sexual function. So they feel really depressed. So this progressive motility of the sperm has to be calculated really in a correct way, whether it is rapidly progressive or if it is slowly progressive, so we can improve the progression of the sperm, or it is non-progressive where it is just twitching, and or whether it is immotile. So second one is the motility. Then comes the morphology. What is morphology? Is the shape. As we saw the sperm at the second slide, the shape of the sperm has to be detected. So this is the motility. The motility, WHO, what they have said is at least 42%, at least 42% of the total number of sperm should be rapidly progressive for the sperm to make the reproduction. Third one is the morphology. How do we do the morphology? We just stain it. So this is how, once you stain it, you see the head, neck, and the tail. And again, these sperms are counted, like 100, 200 sperms, they will count. And then they will calculate the morphology. Depending on this morphology, you know how many percentage of normal sperms should be available to make a pregnancy? You'll be amazed. It is only 4%. Only 4% of the 200 sperms counted, if it is going to be normal, it will create a baby. So it's semen analysis, making a macroscopic and microscopic counting in a proper way, it's very, very important. Everything is done manually by the embryologist. And then what happened was they brought in computer. So it's like computer assisted sperm analyzer, as we are getting more digitalized, but still that count is never matches the manual. But what happens is embryologist quality and the nature, the how many years of experience matters a lot. So again, artificial intelligence have come inside. So this is what this is with computer analysis. This is the fast moving sperms that we see in the slide actually. And then when AI came and artificial intelligence came into us, this is an artificial intelligence machine optometry. This is how the report comes. This is how the report comes. And this is what we have in our IVF lab now. Because if the embryologist is overworked, and then we use the artificial intelligence for semen analysis. If you have any doubts, still we do not believe this AI. And then again, we call our embryologist to have a look and then make a decision on that. So once we are done with our analysis, proper semen analysis, and then what next? Still everything is normal, female part is normal, but still the couple is not conceiving. So what we should advise? How again we can improve the sperm parameter? So what we should do next? What we have to do? We have to assess the sperm function. So exactly the sperm, how it is going to function is very, very important for us. So there are a lot of sperm functions. So how the sperm function works? The sperm has the capacity to go from the vagina, cross the vaginal pH, enter the cervix, which has a mucus, again swim through the mucus, go to the entire uterus. Again through the uterus, there will be two holes at the two end. We have the tube, fallopian tube just coming in. It will select, it will go inside the tube. The tube is around 8 to 9 centimeter. It again travels through the tube. It meets the egg and it will penetrate the egg. Everything has to be done by the sperm. So this penetration, which is traveling the physiological part, all these functions has been taken outside. And this is how we are going to understand how the sperm is going to function. So these are the entire battery test. So each part, sperm mucus penetration, and then how it is going to travel inside the uterus, how it is going to penetrate the egg. So each part is taken individually, and there is every test, at each and every step, there is a test which can be done outside also to study the sperm penetration. The first one is HOS test, that's called hypoosmotic swelling test. Why I'm mentioning this is, see, when we said the motility part, if the sperm is not mobile, if it is just standing still, even if you're going to touch the sperm, it is not moving. We don't know whether it is live or dead. It can be a live sperm or it can be a dead sperm. That is to check the vitality, whether it is really having life or it is a dead sperm. To check on that, what we do is we put sperm in a hypoosmotic solution. It has a plasma membrane. So it draws the fluid and it curls up. If it curls up, then it has a life, isn't it? Then we can take that and use it for the procedure. So this is for the sperm vitality. And the next one is, once the live sperm is there, then how to check the penetration part. So the first one is how the sperm can penetrate the cervical mucus and get inside the uterus. Cervical mucus and get inside the uterus. So that one has to be tested outside. So we do a test. One is called postcoital test. What we do is we ask them to have a sexual intercourse at home and we call them within half an hour and take the semen sample from the posterior vaginal fornix and put it in a slide and then see again. If the sperm count is really okay, if it is moving, we are doing all these tests. And if it is moving well, it is understood the sperm deposition is okay. See, earlier we are not very sure, but this current generation, even though they know a lot, they have lots of doubt on sexual intercourse. You know, they will ask us whether we are doing the right way of intercourse, we are doubting. You know, 2K kids. Can you believe that? 2K kids, they are coming and asking in OP, whether the process of sexual intercourse, is it okay for us? We are doubting. Whether a semen deposition is normal or not, we don't know. Because it's very, very sensitive question. Unless otherwise we give them comfort, they don't come out because that may be a problem for their fertility. So that for those patients, we do postcoital test. And if the postcoital test is normal, if you see the sperms in the posterior fornix, it reassures them and then they can try naturally for their conception. Because all couple wants to try naturally to become pregnant without assistance. That they think that is their pride. So this postcoital test will definitely help them. And the second one is slide test. So we just put it in a slide and then we see the mucus. Second one is we just take the mucus and put the sperm close to the mucus so that whether this is moving inside the mucus. This one is not done really. Postcoital test is okay. And the second one, once it's got inside the uterus to the tube, then it has to penetrate to the egg. This egg has an outer covering because always girls are protected. Even egg is protected. Egg has a nice thick zona which called it will be like one small surface layer of cell. This sperm has to get inside the zona. So that is with the acrosome, which is just 1 minute. Just Geeta, one second. I wanted to introduce our embryologist before I go with the slides. She's Mrs. Geeta. Come, Geeta, 1 minute. So actually, all the semen parameters, all the sperm and all work has been done only by our embryologist. And she is Geeta, our embryologist. Nobody would have seen her actually. We are actually associated for 23 years. And then for the last 12, 13 years, we are in our department, me, Lakshmi Madam and Geeta. For the last 12, 13 years, we work as a team. And she's an in-house embryologist. And she's always in the lab. She's leaving because we have got a case at 9 o'clock. Because all creations, all picking, if she says the sperm is okay, we know the embryo is good and we get a good pregnancy. So thanks for the time and thank you. Thank you, Geeta, for all the help till now.
Thank you, madam, for introducing me.
Thank you for the break. Because the embryologist part is very, very important. Now, without her, we won't be able to do any success. If she gives a good embryo, then we know the pregnancy is really good. Okay, moving on again. Coming to acrosome reaction. The sperm head has an acrosome. This acrosome will go and hit the oocyte and then it will melt the outer part and then it has to enter. This oocyte is like a carrier. It just engulfs the embryo. It just engulfs the sperm. It just accepts the sperm. All the activity has to be done only by the sperm. So how to check this acrosome reaction is, this is how we stain it. We have to stain it again and then we have to look into it. So when you see, this is the head and this brown one is not a good sperm. Can you see this tip is which has the acrosome? So it stains in a different, the post acrosome area will be brown. This is a healthy sperm. So once we know out of the majority of the sperm has an acrosome with a post acrosome brownish area, then we know all the majority of the sperm has a normal acrosome. We can take them to a normal simple assisting procedure. But if this is going to be like this, entire, like if we scan around 10 sperms and we see only this one out of 8 out of 10, this is not going to work. We have to counsel them for ICSI and then even to donor. Even if they have 80 to 90% count, 90 million count, if this acrosome is not okay like this, it's not going to work out. So we have to counsel them, we have to show the slide and then we have to tell them your acrosome is not okay. So you're not able to conceive even with a normal good count. So we have to proceed with the other sort of modalities. And then we saw them leaving off the head of the sperm, next comes the neck. After neck, we saw the middle piece which has a lot of mitochondria. This mitochondria also can be, activity can be also judged. It is again with a stain. I'm not going to the depth, but once you stain it, you can see two colors. One is yellow and one is red. Red is not okay. There is no mitochondria in this sperm, but this is okay. So we have to select, okay, if this is more in the entire slide, and then again we can counsel, we can go ahead with the normal trial. But if this is more, then we have to tell them this is not okay. So you have to get some assisting procedure. And then once the head is done and the mid piece of mitochondria is done, we know the assessment of the sperm function. And then comes the anti-sperm antibody test. What is that is when there is any breach in maybe due to torsion or any trauma on the testes, or if they have any football, they don't even know, they would have forgotten actually, with a cricket ball injury, football injury, hitting themselves somewhere, falling down, some breach on the testis barrier, then sometimes they will be developing anti-sperm antibodies. So when it will not be detected at all unless otherwise we do. When we collect the sperm and then put it in the microscope, it will be agglutinated and it will be really aggregating. So that will be indicating us there is some anti-sperm antibody in the semen. So we have to treat them like autoimmune problem and we have to correct them with steroids. So the intricate details of the semen parameters will be helping a man to have a normal baby. It's not going to the depth, it is anti-sperm antibody test also can be done. Now, after assessing the semen penetration part, okay, it is going to help us only in assisting method. Still, they are not conceiving. So, what next? Then we have to get into the intricate part of the sperm head, because sperm head is the majority which is going to help us in giving a normal euploid embryo. So, we have to get into the DNA component of the sperm head. So, we have to there are a lot of tests which will be helping us to know the exact DNA component of the sperm head. Normally, when you conceive, what happens is, so this is indication for sperm DNA, where there is unexplained infertility, they are unable to conceive irrespective of all treatment, they are conceiving, they are having losses, we are creating embryos, keeping it in the uterus, but still they are not conceiving. Then we have to go into the sperm more than the egg. So that's what we are trying to tell the couple. It is concentrate more on the sperm and not on the egg. Egg maybe it will be normal, but the sperm may not be normal, which is looking normal. So what are the tests for the sperm DNA test? The sperm head has a DNA loops which is really concentrated in the middle. So this DNA loop is attached to a nuclear protein. So there are a lot of media. It is not like one hand we can't do. We need media people also, lab people to give us media. So we have to put the media on the sperm. It will denature the nucleus protein so that DNA will disperse. All the DNA will disperse. So this dispersion test has been done on the sperm. How does it exactly look? So this is how it disperses. This is sperm head. This is very normal. Once you put the solution on the sperm head, it just disperses, making a large halo. If this type of sperm is there in the entire slide, I'm very happy, telling that the sperm DNA is very good. Sperm dispersion was good, DNA dispersion was good. So these sperms are normal, still they can try, and then we have to concentrate on the female counterpart. If this is like this, there is degraded or no halo, then we have to be concentrating more on the sperm part. The idea of creating a baby is to concentrate more on the sperm or oocyte. That is what we have to know. As a couple, we give an emotional thing, making them to come back to the procedure again. But where to concentrate becomes a big question when we have failures, whether it is on the oocyte or the sperm. So all this DNA test helps us to concentrate which gamete we should concentrate more. So this is again, it's a nice sperm. If disperses like this, really, if majority of the sperms are like this, then definitely they can go with a normal conception. And nowadays they're coming like proteomics, metabolomics, I think in all molecular proteins, in all field of medicine, I think they're coming with all this process. Still, it is not into the technology, but it is on the process of other way of checking the sperm capacity. Okay. Now, the second part, we did the penetration. Third one, we assessed a little more bit on the sperm DNA. Now, still they are not conceiving. Then what is our part? In lab, what you're going to do? We have assessed them, but we have to support them. We cannot tell, this is your problem, so that is why you didn't conceive. It doesn't end there. As a medical profession, we have to assist them in a better way. So what we do with the sperm inside our lab? What we do is, once we collect it, we do lot of processing. A simple technique is simple wash. This is called simple wash because we believe sperms is moving. So we just wash it with a culture media so that all the debris is removed. It will gain some proteins from the wash media and it will pick up its motility again. So that sperm is injected, just put it inside the uterus so that they will conceive. It is just a simple wash. Second one is swim up. So we allow the sperm to swim up. We take a conical tube, we put the sperm and we put the media so that what happens, we centrifuge it. And then what happens is the sperm will try to move on its own flagellar activity. Whichever sperm is moving up and then we collect the sperms and put it inside the uterus. This is the second one. Third one is, this one is the third one. It is an advanced, we are all doing this till now. This is density gradient. This depends on the weight of the sperm. If the DNA component is very much good, the sperm will descend down slowly during spinning. So we are just collecting the sperms which is spinning and coming down with a good DNA component and then taking it and then again doing it in IUI, intrauterine insemination, or using it for the IVF procedures. It's called density gradient. So either wash it or make the sperm to swim up by itself, or because of the DNA content, make the sperm to just settle it down and then picking up the sperm. This is how we select the sperms. And when we do an ICSI, this is what the basic assisting method. When we go for an advanced is doing intracytoplasmic sperm injection, which is called an ART, which is like commonly it is called test tube baby, where we inject one single sperm inside one single oocyte. So the importance of selecting that single sperm to put it in the uterus or to put it inside the oocyte is very, very important. So one, it cannot be taken with judgment. பார்க்கறதுக்கு நார்மலாக இருந்தது அதனால் பிக் பண்ண அப்படின்னு we cannot allow our embryologist to take it. So we have certain techniques to pick one single sperm, which is called PICSI, which is called physiological intracytoplasmic sperm injection. See, the oocyte has a hyaluronic acid around it. The sperm is going to enter the hyaluronic acid. So we take that hyaluronic acid, it is prepared by the lab people, and we keep that like this. And then we allow the sperm close to this hyaluronic acid. That sperm will go and attach on this. So whichever sperm goes and attached on these three hyaluronic acid droplets, we pick that sperm and put it for inside the oocyte for creation. So this is called physiological ICSI procedure. This is one way of selecting one single sperm because some men will have only one sperm or two sperm. Normal count is 80 million sperm. 1 million is 10 lakh. But even one or two sperms can be produced by men. So selecting that one sperm which is good is very, very important for us. And after even selecting physiological ICSI, how more we can get into advanced to collect the better sperm. Again, we have to select the best of the better. In that where we use the biomechanics. What is the biomechanics? This we believe the sperm, how it is moving. This is a very, very newer one. We have got all the dishes and we're using it for sperm selection. How does it work is, How does it work is, this is of using the microfluidic sperm sorting. So there will be dishes like this. How does it look? It looks like this. It has 4 holes. Okay, and then we have to allow the sperm sample to get in here. And this sperm will go through a channel here, it will go through the channel here, and it will go through the collection tube here. So whichever sperm is moving faster, whichever is ascending, not good sperms will come down. Motile spermatozoa will be moving up. So this will go to the upper part. So whichever sperm is moving faster and reaching the upper part of this well, we take from there and then use it for the procedure. All the debris, immotile spermatozoa, all will go to the lower level. Upper level will, because sperm has to ascend. If the well is up and we are putting the semen sample here, if it is trying to move here, and up till here, it is a real good sample. It's a real good sperm. And we select the sperm and then use it for the ICSI. This method is by using the biomechanics. It's called microfluidics. It's very, very newer concept. And there's a lot of dishes like this which has come up and we are using this also for sperm selection. And this one is a real old one. They were using magnetic columns, which is tagged with protein, so that with that magnetic power, the sperm will attach. All normal looking sperm will descend down, but this is not used anymore. So let's not go into the depth of it. And this is very newer one, where the microscope magnification, the normal magnification is only 100x. This ICSI microscopes has magnification of 4000 to 8000. There are still more ICSI microscopes, bigger microscopes, which is like about 10,000 magnification. So with that, we can even see the organelles. So we can see the organelles of the sperm and then detect if it is normal and then select the sperm. Okay, now if the men cannot produce any semen sample, what next? We have to take the sperm from the testis. So we do a testicular biopsy. It can be microsurgical, you can use a microscope or an open testicular biopsy, or just put a needle from the epidermis and then aspirate. Our Sarveshwaran sir, our urologist, all of us will help us to collect the semen sample. So collect the testicular sample. Once we collect the testicular sample, we put it under the microscope immediately, and then we tease the seminiferous tubule and we look for the sperms. We see only few sperms, 3 or 4 sperms, and then we pick it and then use it for the procedure. So it can be done once we retrieve through a surgery. It is by mechanical dissociation. It has to be very, very careful because we cannot puncture the sperm. It has to be very, very careful to tease the sample and then you have to pick the sperm. If not so, we can use the enzyme also, that is collagenase. So mostly we'll be getting, unless otherwise they have a completely non-obstructive azoospermia with some genetic abnormality, we will be able to get some sperms from the testis, and which can be frozen and used for later procedures. So that is how it is very, very important in selecting our sperm actually. So once we select a proper sperm, definitely we are going to have a lovely baby in hand. Thank you for patient listening.
All urologists here. So we'll start from Dr. Panisami sir. Doctor, very nice presentation. Can you explain something more about the Y chromosome microdeletion?
Deletions. So it's actually Y chromosome microdeletions occurs in an azoospermic individual. Why they are azoospermia? If they have no sperms, then we have to go for the genetic testing. So that has to be done. It is not done in our lab. So we have to give it to them outside in the lab. We have to collect the blood sample from them, and then we have to give it to the outside lab to check the Y chromosome. This Y chromosome has 3 parts actually: azoospermic factor A, B, C. So they will check this intricate chromosomal pattern on the Y chromosome, and they are going to give us that this Y chromosome has microdeletions. You know, sir, if A and B has microdeletions, we will be able to retrieve the sperms from the testis for sure. But if they're going to have deletions in the C arm, they test ABC, 3 parts in the Y chromosome. If it is going to be deletions in the C arm, then we won't be able to get it by testicular biopsy. So it's always better before we counsel them for testicular biopsy to do an Y chromosome microdeletion to check which factor it has been deficient. If C, we can counsel directly for donor rather than doing a testicular biopsy. That's why this Y chromosome microdeletions is very, very important to do. So before we go in for a testicular biopsy.
So this is done on semen sample? Or?
It is in the blood sample, sir. Y chromosome. Okay. So it's done in the blood sample. And it is done in outside labs. So genetic labs only they have to do it and give it us. And all DNA fragmentation also. DNA fragmentation is done with a semen sample. So we have to collect the semen and they have to give it to outside lab. They will do the genetic testing and they will give us, this is the chromosome. This semen sample has lot of DNA fragmentation of like more than 12%. It doesn't work. We have to, if they have any factors to be corrected like obesity, smoking, or lifestyle, we have to make the men to do that because every day sperms are produced. So from for one spermatocyte to be produced, it takes 72 days. So we can allow them for that 70 days. There's no hurry. We can make them wait for 70 days, do all the alterations. So that what happens is they're going to produce better sperms after 2.5 months. And then collect it again and then do a retrial of procedure. It will work. But they are in a hurry. Once it is negative, they are getting so apprehensive. They go out, they get depressed, eat again, and they smoke, they drink, and they again spoil their health. Again, they come back after 3 months with no alteration. Then we are not able to get a success.
Thank you, Doctor.
Thank you, sir.
Questions?
So Ganesh, sir is
Yeah, Ganesh. We are going to ask questions from all the urologists.
Thank you for giving a very good insight into the embryological aspects, ma'am. That was an excellent presentation. Two, three things I would like to add here. One is about the metabolic syndrome and sperm quality. The metabolic syndrome is the recent thing which comes up which affects every single organ in the body, and the sperm quality is also getting affected with metabolic syndrome. So, treating the patient as an overall patient, treating metabolic syndrome in an overall way brings down right from the increased triglyceride levels to hypertension and other things, also improves the sperm quality overall. That is one point. Second point, while doing a semen collection, what we do here in our hospital is the routine thing practiced all over the world. When a patient visits the hospital, there is a collection room and there is an IVF lab nearby. But the recent studies have clearly stated that the best semen sample can be obtained if the patient collects it at its home. So patient is very relaxed at its home. It can be either by masturbation or post-coital collection, but the best sample collection is happening at home. Only thing which we won't know is the viscosity and the liquefaction time. So if we omit these two factors, we will have the exact volume of, they say that the volume is actually more, 2 ml, 3 ml more in home collection, get it done at a nearby lab and come back with the reports. Then we can test the liquefaction time and viscosity time in our own lab. Thank you.
That's true, sir. That's true. Because when we allow them here, they hear noise outside.
Exactly.
It makes them really uncomfortable.
Exactly.
So we train them not to make noise and don't knock the door and all that. So it works better at home also.
Thank you.
Transport medium to them.
No transport medium, sir. In the normal container only they have to bring, collect it and bring.
So how long you can keep the sperm? Or,
Half an hour, sir. Half an hour. Then the motility stops.
No.
I say,
once you select you are selecting the best out of the better. I presume it is one.
yes, it could be like 3 or 4. You can also store the semen sample for 10 years, sir. It can be stored for 10 years.
Okay. So you have the legal cutoff for 10
Yeah,
years.
for 10 years.
So questions? No, Gautam. There are 2 persons here. You raised that you must complete.
Where are, sir?
Actually, again, the comment, very good presentation, madam. But it is always connected to neurology. So once the autonomic nervous system is working well, you can get enough number of sperms. That is point number 1. And the sperm and the brain shares the same mechanism of exocytosis. Once the acrosome hits the embryo and releases releases along with mitochondria into the embryo. So that was happening in the brain also. What will happen in the presynaptic level? Exocytosis is because of calcium. The same thing is in the sperm also.
Yes.
Because of calcium, it releases
Yes, sir.
exocytosis. Same
True.
thing in the synapses also. So there is a sharing point between the brain and sperm.
Yes, sure.
And one more thing, if you have a sperm motility disorder, we are going to, in future, we are going to have some genetic disorders in the brain, like neurodegenerative disorders, Kennedy syndrome, and dysmotility syndromes, like that.
Okay. So even for talking about this calcium also, we use calcium because that's what I'm wondering, because we'll be using calcium to improve the motility and also to improve the capacitation.
Yes,
so there
yes.
is calcium ionophores at hand, which is already prepared. We use that calcium to improve the sperm thing so
Yes.
that it will penetrate. That's nice.
And we have one drug to stop the motility of the sperm. Anyone have guess?
One.
One drug to stop the motility of the sperm.
So any heat will stop, not even drug.
We have
Just
drug.
heat it, it will stop. Just give it a slap, it will stop.
Okay. We have valproate and sodium valproate.
Valproate.
If you give valproate, the sperm motility will stop.
Okay.
As because the calcium channel block.
Block. Okay. Okay.
Thank you.
Yes.
Whenever a patient comes to you, coming from Veda clinic, he can be the culprit to you. So you can ask him to stop.
The one thing we have
Maybe
to
the calcium is involved in action potential for any cell. So that might be the reason.
Only one thing I have to add on finally, this has to be carried out. Whoever is your relatives or friends, we have to tell, we are creating embryos even with one single sperm. But the problem is the same genetic material, almost 80% is going to be carried by the baby which is born if he is a boy. So we really don't know whether the future what we are going to do. We are just creating embryos with one sperm because nil count we take one sperm and then inject it. But micro deletions they inject it. But the boy who is going to be born for that couple will definitely carry it. And when he's going to become 30 years, we really don't know what he's going to have. So that is the biggest thing. We are just waiting for the future. But right now, the couple are happy, so we are doing it. Thank you.
Thank you, madam. Thank you for the.
At the beginning, I would like to thank the management for giving me this opportunity. And today I'm going to talk about a very important, a basic topic, but a very important topic in pediatrics. It's about growth. Now, the term growth has different meanings in different phases of life. In adult medicine, weight gain is a cause for concern, right, because of the associated lifestyle disorders. In pediatric medicine, not gaining weight is a big concern. Concern not only for the pediatrician but also for the parents. Every parent who walks into the OP is concerned that their child is not growing well, and you have to actually spend some time and reassure them that the child is actually doing good. Parents and everybody often link growth to the nutrition of the child. I do agree diet plays a very important role in the growth of a child, but there are other factors also which are equally important. But for the parents, growth is equal to diet. And that is why a child's growth is often seen as a report card of mother's performance. So the mother is often blamed if the child is not growing well. And we see this often. The emotional distress which the mother goes through is very evident in our day-to-day practice. So we are often faced, actually bombarded with a lot of questions related to growth and nutrition, and it forms the core topic of pediatric practice. Even though the parent feels that the child is not growing well, we as pediatricians have to understand which is the child who needs to be actually worked up. So for the parents, the focus is on the number on the weighing scale, but we know that there is much more than it to growth. Normal growth is a sign of good health in children. Growth reflects a child's nutrition, health, metabolic, hormonal balance, emotional well-being, and overall development. Monitoring a child's growth helps us to identify problems early and act at the right time. So I'm going to introduce a concept of failure to thrive, which means the child is not growing well. This term was coined earlier in the 20th century. It was basically for children from orphanages or institutions. They used to call it the maternal deprivation. So again, there also the growth was linked to the mother. And then over a period of time, it included other causes of failure to gain weight. And now it is known as growth faltering. So failure to thrive or growth faltering is lack of adequate weight gain in the pediatric patients. The three important causes that we explain to our students is it is due to inadequate input, no availability of food, difficulty in swallowing, cleft, there is an obstruction, hypertrophic pyloric stenosis, partial bowel obstruction, so on and so forth. Increased utilization if the child is having an underlying heart disease, lung disease, inborn error of metabolism, some metabolic condition, or excessive output, which happens with malabsorption syndromes, chronic diarrheas, your renal tubulopathies. So all this causes failure to thrive. It is defined as weight for age or weight for length below the third percentile or a drop across two or more major percentile lines on the growth chart. It is not a diagnosis. It is a sign. It's a red flag sign that this child needs further tests to understand what is the cause for failure to thrive. So I'm going to present three cases, three infants who presented with poor weight gain and how we went about evaluating the same. So instead of the routine presentation, I thought we'll go in the chronological order in which we see the child in the OP. So the first thing that comes inside the room is the OP sheet, which has the age of the child, a 3-month-old male child, and we have the anthropometric measures. So this child is now weighing only 3.3 kgs. Now it takes some time for the baby to come in. Now why does it take time for the baby to come in? Because the baby is completely undressed for getting the weight done. So the parent has to redress the baby. Then there's a lot of cleaning and feeding happening, and then the baby comes in. So I get around a few minutes, to understand what is wrong with the baby. So what we realize here is that a 3-month-old baby has not gained weight. It's only 3.3 kg. Now, if it is a preterm baby, this should have been okay, but the length and the head circumference tells me that this is a term baby. So I plot it on the chart and I realize that the child is having a weight which is less than the third centile. So when they come in, they give me the history that the child is not gaining weight, and that is why they have come. So we need to know the birth history. The baby is a full-term normal delivery, 3 kg, no NICU stay, no admission so far. Next, we need to know about the feeding. The baby was breastfed, and now because the baby is not gaining weight, the baby has been started on formula feeds. The urine and stools are normal. I question more about the breastfeeding and the formula feed, the dilution, the volume, and everything seems to be okay. The mother on probing gives history of vomiting 1 to 2 episodes in a day, no regurgitation through the nose, no fast breathing or cyanosis. The child is otherwise having a normal development history. So this is a child who has come with growth faltering and recurrent vomiting. So these vomiting episodes which used to have the whole milk content outside. So with this in mind, the differential diagnosis would be mostly feeding issues, probability to secretion, latching, improper dilution, feed intolerance, that's always on the top. But we need to think of hypertrophic pyloric stenosis, gastroesophageal reflux disease, some inborn errors of metabolism, the urea cycle defects, the fatty acid oxidation defects, which could present with similar features. Congenital heart disease is always at the back because it's a small child, 3-month-old, and truly speaking, at that point, I never thought of an endocrine disease which came with such complaints. So on examination, the child appears to be okay. There is no cleft, no signs of dehydration, blood pressure is okay. No hyperpigmentation. Genitals is a normal male child, but the stretched penile length is 6 centimeters, which is more than +2 standard deviation, and testicular volume is normal. The rest of the systemic examination is normal. There is no mass, no hepatosplenomegaly, no murmur. And so at the end of the examination, the only positive finding, it looked a little bit significant, but otherwise I have no explanation for this. Slightly enlarged penile length. So feeding issues were sorted out. We checked, got the feeding assessment done, and we realized that the child was appropriately being fed. An ultrasound abdomen was normal, so it ruled out hypertrophic pyloric stenosis. Echo was normal, so heart disease is gone. The baby had a normal CBC. This is the physiological anemia of infancy. Cultures were negative. But what came up on the investigation part was a sodium of 116, potassium of 5.8, and bicarb of 17. LFT, RFT, blood glucose, and thyroids were normal. So now we have a child with growth faltering, recurrent vomiting, hyponatremia, hyperkalemia, and metabolic acidosis. Now this combination is suggestive of aldosterone deficiency. So aldosterone secreted from the zona glomerulosa of the adrenal gland. It acts at the distal part of the nephron and is responsible for the reabsorption of sodium and excretion of potassium. So deficiency of aldosterone can come with a similar picture. And in a 3-month-old, we will think of salt wasting, CH, pseudo-hypoaldosteronism, where there is high aldosterone levels but resistance for the action, and primary adrenal insufficiency, just to complete the list, because such cases present very early, immediately after birth. So the baby was started on salt supplementation, started at 3, required 5 milliequivalents per kg per day, measures to reduce the potassium and bicarb to correct the acidosis. And then the results, the 17 OHP shows a value of more than 20. There is borderline low cortisol and aldosterone levels. ACTH is high because of the loss of negative feedback mechanism. Renin is high because of hypoaldosteronism. So this confirms the diagnosis of salt wasting congenital adrenal hyperplasia, which was later confirmed by a genetic test. The child was positive for homozygous mutation in CYP21A2 gene, which is for CH. This child was now started on hydrocort and fluorocort supplementation along with salt, and the vomiting episode settled. The baby showed weight gain. Now he is a healthy 3-year-old. So congenital adrenal hyperplasia is an autosomal recessive disorder where there is a deficiency in the enzyme 21-hydroxylase, which is important for the synthesis of cortisol and aldosterone in the adrenal gland. Aldosterone deficiency is responsible for the salt wasting, the hyponatremia, hyperkalemia, hypovolemia, dehydration. Cortisol deficiency causes failure to thrive, poor weight gain, hypoglycemia. This also increases the levels of ACTH because of loss of negative feedback. This ACTH causes hyperplasia of the adrenal gland, and that is why this condition is known as congenital adrenal hyperplasia. The precursors, the steroid precursors which get accumulated before the block, will get converted to adrenal androgens. So this causes virilization in a female baby. Salt wasting form of CH is a severe form of disease which usually presents in the first 3 weeks of life. This is what we tell everybody. Salt wasting CH will come in the first 3 weeks with adrenal crisis. And a female baby is diagnosed at birth because of virilization. Newborn screening using 17-OHP test is the only way to diagnose the baby at birth. Presentation at 3 months with failure to thrive, like in our case, is slightly unusual. Not all cases of CH, so this case actually taught us that not all cases of salt wasting CH can present with adrenal crisis. Probably this baby had a partial deficiency, and that is why the baby had some amount of aldosterone and cortisol, and that is why was asymptomatic till date. And CH should be a differential diagnosis in infants with failure to thrive and characteristic electrolyte abnormalities. The second case is a 3-month-old male child, birth weight, the baby has come with a weight of 3.8 kg. which on the growth chart is below the third centile. So has come with poor weight gain, normal delivery, 3.2 kg. So in the last 3 months, the baby has only gained 600 grams. And there's a very significant history of an antenatal scan showing bilateral hydrouretronephrosis. Baby had no UTIs till date. The NCU showed P valves and bilateral vesico-ureteric reflux, which was actually corrected a week back. The failure to gain weight was attributed to the hydrouretronephrosis. This baby was detected to have hyperkalemia during this procedure and was treated for the same and was asked to repeat a value again after a week, and the repeat value showed hyponatremia, hyperkalemia and acidosis. Now this is why this baby was here, because of these abnormal reports. Further probing, breastfeeding was okay, just few episodes of vomiting here and there, no fast breathing, 2-day echo was normal and the rest of the history was normal. So now we have a child with growth faltering, recurrent vomiting, hyponatremia, hyperkalemia, metabolic acidosis with a background of obstructive uropathy. So in this case, the differential again, this is again aldosterone deficiency. So the first differential is a salt wasting CH followed by pseudo-hypoaldosteronism and primary adrenal insufficiency to complete the list. So the investigations, the examination findings was completely normal. The baby had a normal blood pressure, no hyperpigmentation, genitals normal. Rest of the examination was normal. The investigations from our side showed a sodium of 129, potassium of 6.5. So hyponatremia, hyperkalemia, acidosis. Cortisol was normal. Blood counts showed increase in total counts, plenty of pus in the urine culture positive. So the baby had a UTI. And the rest of the test reports awaited. So as of now, we have a child with aldosterone deficiency, obstructive uropathy, UTI with normal cortisol. So the baby was started on antibiotics for the UTI, salt supplementation, measures to reduce potassium, bicarb supplementation, and when the reports were out, 17 OHP is normal. So it's not like the previous case, here 17 OHP is normal, aldosterone levels are high, renin is high. So this is aldosterone, pseudo-hypoaldosteronism, where the aldosterone is high and there is resistance. And since there is obstructive uropathy, this is secondary pseudo-hypoaldosteronism. So the baby is actually electrolytes normalized with supplements, and by 3 months we were off supplements. The baby was absolutely okay. Aldosterone and plasma renin activity was normal at 1 year of age. The growth improved. The genetic test for primary pseudo-hypoaldosteronism was negative. This is a now healthy 7-year-old who is completely off supplements. So the diagnosis was pseudo-hypoaldosteronism secondary to obstructive uropathy, and this is a transient condition. It usually resolves once the obstruction is taken care of. So pseudo-hypoaldosteronism is a rare condition where there is resistance to action of aldosterone. So we know that aldosterone acts on the principal cells and intercalated cells. This is the aldosterone receptor. It acts via the epithelial sodium channels, causes reabsorption of sodium and excretion of potassium. So in pseudo-hypoaldosteronism, primary, there is a genetic condition where there is a resistance in the receptor. So there is a mutation of the aldosterone receptor or ENaC, and that causes features of hypoaldosteronism. In secondary PHA, this is a transient condition where there is renal tubular resistance to aldosterone. When a child has a UTI or urinary tract anomalies, and especially in infancy, and the clinical presentation is non-specific, but the uncorrected metabolic disturbances can be life-threatening. The hyperkalemia can be dangerous. So it is very important to identify this condition and should be considered in a child who comes with failure to thrive with urinary tract abnormalities, UTI, and the characteristic electrolyte disturbances. And the last case, this is an 8.5-month-old female child who presented with a weight of 4 kg. So the again chart shows that the weight and the length are below the third centile. That tells us it's a very severe case of failure to thrive. Came with poor weight gain. The birth history was normal, birth weight of 3 kg. So baby has only gained 1 kg in the last 8.5 months. Feeding history is also okay. Breastfed, formula fed, solids was already started, but the mother was quite sure that the baby passes a lot of urine and is excessively thirsty. So she keeps on asking for feed every half an hour, 1 hour. She had histories of vomiting episodes, no regurgitation through the nose, no fast breathing or cyanosis. The rest of the history was okay. Development-wise, she was not able to roll or sit because she was not she had not gained weight, so she couldn't even roll and sit. So now we have a baby with growth faltering, recurrent vomiting, polyuria, and excess thirst. If I look at the differentials here, I will think of a renal disorder, renal tubulopathies, like the renal tubular acidosis, Bartter's, all these syndromes where there is loss of electrolytes in the urine and causing polyuria. Nephrogenic diabetes insipidus, right, there is impairment of the renal ability to concentrate urine. That can also present at this age. Metabolic inborn errors of metabolism, cystinosis, Fanconi syndromes, everything can come with similar symptoms. And I don't know, sometimes neonatal diabetes also. We do get cases where the child comes with only polyuria and then has the high blood glucose levels. So on examination, this baby was conscious, alert, BP is normal. This baby looked very shrunken, shriveled, had dry and cracked skin. No hyperpigmentation, no signs of rickets, genitals normal. The rest of the systemic examination was completely normal. And I actually tried to measure the 24-hour urine output to confirm polyuria. We couldn't collect all the sample, but whatever sample we could collect was more than 500 ml in 24 hours. So definitely it was more than 5 ml per kg per hour, which confirmed the mother's concern that the baby was passing excess of urine. Investigations, ultrasound abdomen showed bilateral normal sized kidneys with raised cortical echo texture, poor corticomedullary differentiation. 2D echo was normal. And blood glucose is normal. Now the reports here, sodium is 112, potassium is low, chloride is low, bicarb is 31. So hyponatremia, hypokalemia, hypochloremic metabolic alkalosis. RFT showing a pre-renal picture, 95 of the urine and 0.7 of creat. Calcium, phosphorus, magnesium normal, TSH normal. So I rule out diabetes insipidus because of the low sodium. Diabetes is gone because of the normal blood glucose levels. And I'm actually left with renal disorders or metabolic conditions. To check for urine excretion of electrolytes, urine routine was normal, there was no protein. Calcium create spot ratio was normal. Urine sodium and urine potassium is high. So it tells us the baby is losing electrolytes through the urine. So this, with a picture of metabolic alkalosis, hyponatremia, hypokalemia, goes in favor of Bartter syndrome, which was later confirmed by a genetic test. The baby had deletion of chromosome 1, including this gene. This gene codes for Bartter syndrome type 3, which is the classical Bartter syndrome. So the baby was started on high dose sodium. Baby was actually needing so much of sodium. We had to go up to 10 milliequivalents per kg per day. Lot of potassium. Doses were titrated as per the values. Actually, the mother adds extra salt in the diet. Even now, we add extra salt in the diet. Baby actually has started having salt cravings. So baby herself asks for salt and potassium-rich foods. The growth significantly improved. In the next 3 months, the baby actually gained 2 kg, started sitting up and rolling over. So we could see an improvement in the developmental milestones also. So completely got better. She is under supplements as of now. This is a rare salt-wasting renal tubular disorder of autosomal recessive inheritance where there is a mutation in the gene coding for this co-transporter, sodium potassium 2 chloride co-transporter in the thick ascending limb of loop of Henle, which causes loss of sodium, potassium, calcium, and chloride in the urine. So there is metabolic alkalosis, hyponatremia, hypokalemia, hypochloremia, and because of the hypovolemia, there will be hypereninemia, hyperaldosteronemia. There's a normal blood pressure because of the chronic hypovolemia. Some children may have excess of calcium excretion in the urine and nephrocalcinosis. Now, type 3 Barters usually does not have hypercalciuria, so they do not have nephrocalcinosis. So we need to consider Bartter syndrome as a differential in a child who comes with failure to thrive in infancy with characteristic electrolyte abnormalities. So the take-home message, failure to thrive is a clinical sign. It's not a diagnosis. It's only the tip of the iceberg. So the thing which you can see at the top. Every child with failure to thrive deserves more than a weighing scale. You need to search for the diagnosis which is hidden behind the numbers. So you actually need to search for the submerged part of the iceberg. As in our case, 3 cases, the electrolyte abnormalities could serve as an invaluable diagnostic clue. So failure to thrive in the first year of life, we need to do serum electrolytes. Otherwise, we may miss all this. Serum electrolytes, most of the times we think it is not needed. But this is very, very important. We need to look at the electrolyte abnormalities as one of the causes for failure to thrive. Early diagnosis, targeted treatment can reverse growth failure, prevent adrenal crisis as in the first patient, and severe electrolyte disturbances and improve long-term outcomes. Thank you.
Thank you, madam. A very nice, interesting presentation on aldosterone problems.
Yes.
Questions? So, in internal medicine, yes.
Now we see for infertility patients with typical features of PCOS, they are like androgenic and all that. And when we check, they're having non-classical CAH. Should they be addressed early or something, or on supplements they are okay during pregnancy? It won't be a problem. We have doubt on that.
So non-classical CAH is the most common and very close differential for a PCOS. So when we get an adolescent child who presents with PCOS, oligmenorrhea, acne, we always do a 17-OHP to confirm that whether it is non-classical CH. And they say non-classical CH actually does not need steroids and fluorocorticoid supplements. Unless the symptoms are very severe. So if the child is having a lot of acne and lot of hirsutism, then in that case we do give supplements for a few months and we correct the same. So, but it definitely lands up with infertility and you may have to treat the child. Thank you.
It was a high-grade vesicouretic reflux. How was it tackled? Reimplantation or reflux injection?
No, sir.
Or
Only the
multiple-
PU wall fulguration was done, sir. And only because that was a very tight wall there. So only that was done. And then progressively the child's reports turned out to be normal.
Can you show the MCU picture of that?
Yes, sir. Yes, sir.
The posterior urethra seemed to be normal actually.
Is it, sir?
In PUV, posterior urethra is dilated. So it's primary reflex perhaps. It's not posterior urethra.
But it was treated as the posterior urethral wall, sir.
Treated.
Yes, sir.
This is after the treatment.
No, sir.
No, posterior urethral basic diagnosis done by dilated posterior urethra.
Sir, by the cystoscopy, sir.
No,
Yes, sir. Yes, sir. On this, yes, sir.
MCU. It's
Yes, sir. Yes,
widening
sir.
posterior urethra. It's a widening film, no?
Yes, sir.
Posterior
No,
urethra
sir.
is
This
not
is
there.
an X-ray from outside, sir. So I don't know, but then they did a cystoscopy and they found a posterior urethral valve and it was corrected, sir.
But anyway,
Super. First two cases had the same electrolyte imbalance and the challenge
Yes.
is in identifying things. Very nice presentation, ma'am.
Thank you,
Third
sir.
case in Bartter syndrome, we do a temporary correction. I do agree with you. In 3 months, we have seen weight gain. Now, what answer do we have for lifelong problems?
Yes, sir. Sir, actually there is a role for NSAIDs, use of ibuprofen, indomethacin in these children, and it's supposed to reduce the prostaglandin levels in the kidney and help the child grow. So actually, since the child responded very well to salt supplementation, I actually given a course of ibuprofen for 3 months. But the creat level started tipping off, so I just stopped it. Maintaining on salt supplements as of now, they say classical Bartter's gets better with age. The child, is able to manage the electrolyte disturbances with age. The other forms of Bartter's are risky. Even a small infection can actually tilt the child into severe electrolyte disturbances and can cause death also. This child is having classical type 3, so doing well. She's now 2.5 years old. So we are just waiting. Yes, sir.
They have neurodevelopmental outcomes and their behavioral issues later in childhood. So-
Yes, sir. So failure to thrive, the definition itself is basically for the weight. But if the failure to thrive becomes chronic, if it's a long-term thing, then the height is affected and finally the head size is affected. And that is when the developmental issues crop up. But this is early infancy, the head size, the head circumference is normal, and all the 3 kids are doing developmentally well. So probably if the electrolyte disturbances are severe and the child is having any issue because of that, then maybe the seizures or something, then that may affect the development. But in these 3 cases, development, there should be no problems as such.
Thank you, madam. So, primarily when the understood problems for the adrenal problems, they present with very non-specific symptoms.
the diagnosis always suspected and led by this electrical disturbance is very crucial, and also in patients with hypertension.
Yes, sir.
To pick up the secondary hypertension, these potassium disorders, either it is in the renal artery or in the adrenal cortex or in the aldosterone pathway, the potassium is so paramount important, so it leads to diagnosis. Thank you all, and
Thank you, sir.
thank you for the wonderful presentation, Dr. Suganya and Dr. Sobi Anandi. Thank you.